generate savings required, and their ambitions were large in scale. Now, there's versions of this statistic shown on the slide, but one drawn from the key shows that only 5% of change ever fully materializes the intended benefits. Something we'd recognise from working across the NHS. I'm sure many of you will recognise this is the change model, which is based on our collective experience of what works. The model isn't an end in itself, it's there to support the delivery of change as a framework. We know paying attention to each element maximises the chances of success. And people have access to different elements, and what we do in our delivery is to facilitate all the change conversations. So we have huge carpet mats, and we have people in the group who are from CCGs and their partner organisations. So it's usually CCGs bringing their commissioning partners from local authorities, health and wellbeing boards, provider organisations, third sector and patient representation too. Ask people to walk to where they feel they have their strongest affinity, and then provides a really visual picture of organisation or system leadership team, their strengths, and then ask people to move to the area that they feel least affinity to. And I think that really is powerful in demonstrating both individual and collective need in responding to that. So how do you address some of those areas where you don't perhaps have some of that current capability? Shared purpose, so the centre of the change model, has an absolute critical focus for our work with CCG and their system partners. It's one thing to have very credible leaders of organisations. Now what's asked of those individuals is for them to adopt a system perspective and collaborate as never before. And I think this morning is only going to see obviously a significant other increase with the full view that was being talked about by Simon Stevens and colleagues. And often gets into the realms of seeding territorial resources into new models of care. So really quite difficult stuff. You can see model.nhs.uk for a lot of resources on using the model, and there'll be more developments too, as we've learned a lot about its use from application with work across so many systems. So the next is a commissioning cycle we developed whilst in partnership with the Royal College of General Practitioners a couple of years ago. So it's specifically geared towards clinical commissioning. Really emphasised the focus on community commissioning here, and the importance of collaboration, hence the outer frame, encouragement to build the right broad partnerships. There's a few to emphasise here, beginning with where to start. So in the past, our intended to begin at the specified cure stage, but effectively that's contracting. Commissioning starts with really understanding need and setting out a vision for what you're trying to achieve in improving health and outcomes for a population. Again, the change model which we put at the centre here, this is a framework, it's not a management tool, but I think it's a good cycle, if you like, of being able to follow each stage through in terms of a commissioning journey. With the delivery that we're providing to CCGs and system partners, there's not really a typical single form for how the support has progressed locally, because it's very much driven by that local context. I do think from the wide evidence base that underpins our work, there are some really critical foundations and focus. Analogy in the team of describing large-scale changes, running a marathon. Our contribution, in effect, has been to provide some energy stations in that journey, bring local systems to make sure they're on track and set up well for the long haul. We've talked about extending analogy for describing the reality that CCGs and their local partners are also multi-eventers at the same time. They're having to do both the short and long term simultaneously, and therefore facing a really difficult challenge to give the focus to the long-term agenda as well as reacting to the must-dos that seem to just continually increase. What we see on this route map is often kick off with explaining some of the foundations for large-scale change, which we'll touch on shortly, really distinct from additional service improvement, really kicking off with making sure that there's a clear, compelling shared purpose across partners. Publishing So this is the cover of the publication. And works that I'll touch on, from our work with the account for large-scale change, also the 1997 consensus that we needed to do something about our hospitals, which were seen as outdated and dilapidated, and there are too many or too small. And then in 2000, there started to be a focus on quality and value. And in 2005, effectively, we started to think about the demographics. But in 2008, obviously, the realities of HQIP became a principal driver. So bringing all that together, one of the forerunners to NHS improving quality developed an Academy of large-scale change, which has really formed our learning and thinking since and continues to. So starting point is to define what we mean by large scale. I think there's a couple of helpful ways to think about scale. In this slide, there's 3 dimensions of large-scale change. So it will involve size. It will affect lots of people or cover a large geography. And it will be pervasive and involve changes in lots of processes and systems, e.g. information technology, HR and so on, but across multiple organisations. And it will also involve depth in terms of the impact upon behaviours and the ways of working. So large change to us involves 3 of these, and we typically call it transformational change. Important and often we neglect the depth cause pervasive changes to fail. For instance, when we conceive of the use of IT programs intended to be pervasive, it's been accompanied by some of the deep changes in the way that we do things, some behaviours, some of the workforce redesign that need to be wrapped around those for them to actually signal a shift. And do they represent a paradigm shift in the way that we work? Our assertion is that the behaviour, the cause effect, is not mechanistic, it's not automatic. And the Academy showed through real work that changes at one level can influence other levels in which it can be difficult to predict. I mean, there's a whole discussion here about to find perfect solutions for fundamentally quite messy problems. And that's obviously something that we struggle to grapple with. And there's the ripple impact of system-wide effects from small initial changes. The mission that the system, the individual parts, adapt during change, in which these are often difficult and impossible to predict. Working definition that we find useful for framing large-scale change, and I've highlighted in red some of the key principles about it being emergent, about it requiring mobilisation of a large group of individuals, presenting a vision of a fundamentally different and new state. So a model for large-scale change, and I apologise that this looks a little complicated. I'll read through it and hopefully bring it to life. So to our delivery at the moment, we'll talk about where we've got to so far. So with local systems that have often started to articulate the need for change and to frame the issues, had set up conversations with local sponsors, and you will have kicked off with an early visioning session, and conversation I described earlier. And will, through those sessions, have thought about scale and started to use that to frame issues. And by each of them being in the room, they're starting to work together, engaging, they're connecting with each other. So the first group of others, engaging, connecting others, is effectively us. It's the folk that are in the room. Start to talk about the need to move on and make pragmatic changes, and use those to help reframe the issues and attract further interest. Some of the difficulties, obviously, the outcomes might not be known for some time, especially with large-scale change. But typically there'll be one of those outcomes in the sort of settling in the possible outcomes box there on the right. But it's likely to be a really continuous process, constant feedback loop. So what we try to is that there's a sufficiently well-defined topic area, a priority area, a local priority area that people can connect with. On there's both a specific mix of pressure, will, incentive, attraction, consequences, and so on. And that's felt by a small but large enough group of people who find some means to exert some influences over them at multiple levels. So service delivery, handover processes, clinical decision making, financial flows, public opinion, policy drivers, and so on, to changes in a sufficiently effective and visible way. And this pattern of framing and reframing in the model, being others, initiating changes at multiple levels, repeating that many times in sometimes hard to predict ways, and then really being generated by the appearance of success, making sure that that's then communicated widely enough and effectively acts as an attractor to others who are perhaps previously neutral to join in some of those activities and actively support the process of change. And that thereby starts to create another cycle of framing and reframing, engaging others, and initiating change at multiple levels. So this momentum then continues for some time until either our hypothesis is that the effort effectively runs out of energy and simply fades away, or the change hits a plateau at several and no longer attracts new supporters. The change becomes reasonably well established. The steps across the system have made changes to accommodate or support it in a sustainable way. Shortfall, the measured results and the unintended consequences from a really true-scale change endeavour are often not known until sometime into the future. Therefore, throughout the process of large-scale change, a certain amount of keeping faith, intuition, judgment, and moving forward on sometimes an incomplete evidence base is going to be inevitable. 3 slides are summaries of the principles behind this, and I spoke down earlier and know that you'll get access to the slide deck, so I'll label these. I'll just put them for a couple of moments. That's the first 5 principles of the model, and then the second 5, and all contained within the publication and all available online. And just put up some indications for the change process there. Again, just reinforcing the importance of a vision and key themes, agree the need for change and have an ability to initiate that change process, and be pragmatic in that the initial changes might be limited, but it's important for them to have the appearance of success, and then a communication effort to bring on board others, and lots of cycles of framing, reframing, change and attraction. So first on lots of lots, if you like, which is perhaps a clever way of saying it, but I think this, grappling with this and perhaps its unwieldy form is probably well summarised by lots and lots. So wrap up then, really key to our work with CCG and local system partners has been the importance of collaboration and broad partnership. That's absolutely fundamental. And then generating commitment as opposed to compliance. I conveyed that the impact of shared purpose with a clear vision, really well consistently articulated by every part of the system, is absolutely crucial. We talk about something called loose tight properties. So it's a piece around managing absolutely what needs to be managed, but also feeling comfortable with some of the freedoms that need to take place, and some of the enabling that needs to be done by those folk implementing the change, not just the sponsors of the change and the chief officers groups. Finally, really, I hope finesse through what we're doing is learning through doing. Certainly don't think in the way that basically that these have on their agenda. People want very practical support focused on real priorities. And pull out the learning as we progress that. The overwhelming focus is on real work and moving forward that local issue. So I'll wrap up there, and Sam will coordinate a few minutes for questions, I believe.
That's great. Really interesting, informative slides there. A question asking, when you talk about pervasive large system change, do you see as one large change or as lots of small scale, perhaps PDSA cycles?
Yeah, I think in conception, large scale change, so whether it's rethinking frail elderly delivery or a particular aspect of the system. I think constructive is probably going to be, very broad and pervasive, but ultimately it's going to get in the way through things like PDSA cycles. Sam and be able to, as I said, to demonstrate success, to demonstrate impact, and to demonstrate that there is movement, and to pull some of those folk to act as an attractor effectively, persuade folk that this is business, and basically we're going to make some headway for this. There's commitment and sign up, and resources and capacity in order to undo that. But you're right, PSA certainly speaks to the lots and lots that I was referring to.
That makes sense to me. We have a question asking if you've had much feedback about using this process and what it's been.
Yeah, we have. So there's we've got 3 lines of evaluation. First is participation on the day. So when we're delivering in one-day workshops, and typically work with a CCG system, CCG alliance with the local partners for about anything between 6 and 9 months, and we'll probably typically deliver 6 or 7 workshops. And delegates are telling us that really good things in terms of rating the quality of delivery. I've got a really strong team and a faculty of people who look like the people that we're working with. They're jobbing clinicians, they're jobbing commissioners and improvement experts. There's really good rating around facilitators, but what people are really valuing is their headspace to do this, and ultimately, so unless they make this deliberate effort to spend time this way, they wouldn't do it. The day-to-day conversations wouldn't get them to the place where they need to be to advance change. By supporting and guiding them to focus on a local priority, if it's building some of the trust and respect, that's really key. So some of the relational stuff that's important for system leaders. We've got an efficacy piece, which is about making sure we're building capability. So this isn't about creating dependence. This is about us acting as management consultants. This is hopefully us conveying tools, frameworks, ways of thinking that people can replicate on other aspects of change, on full, large-scale change pieces or small, sort of incremental change. That's coming through steadily too. That people feel they're able to use these. They've been honed in care settings, and they resonate really well. And people, particularly our workshops, would probably see us convene the evidence and the approach for no more than 20%, and 80% of it being about practical applications. So folk are genuinely going out of the room with a decent understanding of how to use some of this. And then, importantly, independent evaluation piece. We commissioned McDonald from a number of people who bid, and that the spec for the independent evaluation was agreed with a number of partners, including NHS England. What's coming back is the genuine belief that the added value of the programme and the team supporting CCG's and systems has been an acceleration of the pace and progress of their local ambitions. So in through, which is really encouraging.
Which leads on quite nicely actually to a question from Mandy, who says that one of the major criticisms sometimes is that hospitals or trusts may fail to integrate their clinical audit into their large-scale changes. Andy wonders how you see that working, so how we can integrate clinical audit into making large-scale changes.
I think it's that if you go back to can I take back the presenter rights, Sam, and I'll go back to a slide and show where I think that fits into the, how do we do that?
Just putting those back.
Thank you. So if we go back to the commissioning cycle that we built. To me, so I think here the analyse and plan, so the understanding need, the data piece, through to the designing of pathways and bringing clarity to quality. I think that absolutely is a place where clinical audit plays a really significant role, before we then get to specifying and procuring. Like I said, I think, or hopefully I said in the initial presentation, often rush to that latter stage, but the other planning is the really critical piece. It makes sure that ultimately what we're pursuing is built on the foundations and a really decent understanding of what it is that we're trying to do, whether that's the population need or some of the specialist data that comes in.
Okay. We have a question here from Jenny saying that she's experienced problems in the past trying to implement hard changes, so things like new rules and process changes, that they're now as an organisation looking at softer approaches, so different ideas and posters to promote change. Jenny, if you have a view of whether soft change are right or wrong, and whether your process makes it easier to implement hard changes in a faster way.
Thank you, Jamie. Interesting question. For us, probably our key sort of watch phrases is around commitment as opposed to compliance. Compliance-based change has negative connotations. It's known not to necessarily get the traction that you want, but commitment and explaining shared purpose. So I hope people don't. I know commonly people do talk about them as soft, but they're so critical to get that right. There's some really good stuff, not surprisingly, from NHS Improving Quality about understanding some of that. We have to move to what we describe as dialogic-based conversations, and that's about promoting the importance of relationships and communications. Ultimately, it's around connecting people's shared purpose. And the power of narrative and stories. So if you're expecting, say, for instance, a team or a cross-organisational team or whoever it is to enact something, ultimately you've got to make sure that it connects with them. And then they're able to convey a story or a narrative about what this means for them, what's their commitment to that change as opposed to their complaints. And then how do you build that up in terms of shared purpose? What is it we're trying to do? Is it anchored in improving something for patients, addressing a harm issue? What's it born out of? And will people consistently articulate that? So if change does hit the buffers, people can say that's actually what this was is about. And how do we revisit it? How rather than sort of abandoning what it is that we're trying to do, how do we learn from some of the instances when things don't go quite according to plan? But then he's right that the emphasis of soft alongside some of the harder the process changes is really important, and I'd really encourage folks to think both hand in hand if you really need to make sure that change is going to be effective and sustained.
Probably have time for maybe 2 or perhaps 3 quick questions. I'd quite pick up on one that message saying that she's interested to hear some examples of those appearance of success changes, so that have moved other large changes forward. Any specific examples you can give us of those, Charlie?
I think probably the best. So I've not worked in a national improvement organisation. I've had real jobs too. And before I joined the NHS Institute, and now obviously part of NHS Improving Quality, and I was commissioner for the better of the last decade, and worked in a number of provider organisations too. And I think that gave me a decent understanding about actually change has to have a benefit for each part of the system. So if I look at some work in Nottinghamshire, led by a colleague of mine, around utilisation in effect, or broadly it was more around clinical utilisation. It was about patients to hospital, and was it clinically appropriate for patients to be admitted to hospital? And in most cases it was. The overwhelming majority, 90% of cases, it absolutely was. But at some point during the stay, that wasn't, an acute setting wasn't the appropriate environment for them. They could be supported in a different setting. So this shared. It was critical. It was led by an independent agency, part of the the old SA infrastructure in effect, but it was McKesson who provided it. But getting to the table and being able to say, okay, what does this mean, and ultimately, how do we respond to this? And it is a bit of an enabler, and it addressed several things. So we looked at, mindful of there's not much cash around in the system, and there's very rarely the opportunity to double run with some of this. So it requires some serious good faith of people to fundamentally change models of care and provision whilst something else gets up and started. But what happened, what came through as a result of this one was some reduction, planned reduction in some of the acute beds, some utilisation of some of the community hospitals, but also some reduction in the bed capacity of the community hospitals, because a real drive on care planning. So getting social care into the room and into the discussions, and really conveying the importance of that as a massive factor causing issues across the system, and identifying some of those working process delays and getting those into a timely way, and then also being able to test them through just the annual cycle of resilience, and that being able to withstand seasonal difficulties and so on. And what with was patient experience, measurably improved patient experience, reduced acute beds, reduced community hospital beds, vision of disused wards in the community setting to actually provide, I'm trying to remember what it was, but I think it was a local dialysis unit. In the end, it ended up being provided. Again, benefit patients who weren't having to travel across the city or county. In social care, not being seen as the sort of culprit, actually part of an active team. It came about through testing one part of the system and basically making sure that the processes were functioning, and then being able to have the discussions around confidence and pull-out capacity, and then everybody's efforts to sustain it and to learn from it, and then to think, actually, if we get this right, where do we take it to next? Ultimately, we seem to have got an approach here, a functioning, working approach. Where do we take this to next? That was a long way of explaining. I'll probably cut out the last couple of questions. Sorry.
No, that really helps. Well, thank you. I think that's all we've got time for at the moment. Charlie, will you be able to join us on Twitter this evening? Do you know?
I try. I'm not talk about getting me on the spot, but I'll do my best to try and join you this evening. I use Twitter, so it's at Charlie Keeney, all one word, and I'll definitely do my best to look out for you.
That'd be really interesting if you could do. As well, on the webinar audience today, the Twitter chats will be starting at 6:30 this evening, so that gives you time to get home and log on. You can have a discussion, which will be following on from this webinar, use #ClinicalAudit, which is all one word, or in the tweets of @HQIP, and we'll be retweeting things so that you can follow it a bit more easily. Really to join us and give us your views about this, perhaps tips you've got for other people in achieving large-scale change, and what you think the key things are to think about for clinical governance staff in successfully achieving large-scale changes in your organisations. Thank you very much, Charlie, for your talk. The slides, the recording will be available shortly on the HQIP website, and notify you when that starts. You can also listen to recordings of the other webinars from earlier in the week. And if you haven't already, there's still some time to join up for tomorrow's webinar, where we're hearing from Kat Young from NHQIP, the National Quality Improvement and Clinical Audit Network, giving out her tips for sustaining and evidencing change, including all of regional networks. Thank you very much for joining us. Apologies if we didn't get to answer your question, but please do join us later on Twitter and we'll address and talk in a bit more detail. So, thanks everybody, and I hope to see you tomorrow.